Hello everyone, myself Dr. Rajni Agarwal, Professor and Head, Department of Periodontology and Oral Implantology, Surendra Dental College and Research Institute, Shri Ganganagar, welcomes you to the session of endodontic-periodontic interrelationship. Now, what is endodontic lesion? It is an inflammatory process in the periodontal tissues which results from the noxious agents which are present in the root canal. Whereas periodontal lesion is an inflammatory process in the periodontal tissues which results from the accumulation of plaque on the external tooth surface. Now, why do these lesions occur? It lesions occur mainly because of the living pathogens such as bacteria, fungi, virus. Now, we know that plaque contains bacteria, then the root canal caries occurs which contains the live pathogens such as bacteria, fungi, and viruses. Also, non-living etiological agents results in the lesions can be foreign bodies, can be cholesterol, Russell bodies, Russian bodies, Highland bodies, charcoal leaden crystals. They can all be the etiological factors for the endoperio lesions. Now, those were the primary etiological factors, whereas certain contributing factors which promote the lesions are poor endodontic treatment, poor restorations, trauma, resorption, and perforation. Now, how do this communication occur between the endodontic lesions as well as the periodontal lesions? It is through the developmental pathways, or it can be through the pathological pathways, or it can be iatrogenic. Now, developmental pathways. As we know, the most common association between is the apical foramen. That is at the apex, the root canal. It is communicated with the peripheral structures. Also, lateral and accessory canals and dentinal tubules. They can be in direct contact, which can result in the communication. The pathways of pathological origin include empty spaces on the root, root fractures, idiopathic resorptions, as well as loss of cementum due to external irritants. Pathways of iatrogenic origin include the perforations, the exposure of dentinal tubules after scaling and root planing. Then during endodontic treatment, root fractures can occur that can also result in the communication. Now, what is a classification of endoperio lesions? It was given by Simon in 1972. It included as primary endodontic lesion in which the endodontic lesion is present, primary endo lesion with secondary periodontal involvement, primary periodontal lesions, primary periodontal lesion with secondary endodontic involvement, true combined lesion, and a concomitant pulpal periodontal lesion given by Belk Cutman in 1990. Explaining this, first is the picture showing the primary endo, that is only endodontic lesion is present that can result in inflammation of the surrounding structures, that is the primary endo. Then is the primary endo which causes the inflammation of the periodontal structures, that is first the endodontic involvement is there, then it has resulted in the involvement of the periodontal structures resulting in primary endo and secondary perio. Then comes the primary perio, that is the only the periodontal structures they are involved because of the presence of dental plaque. Then is primary perio and secondary endo. That is first here the plaque was present, it resulted in the periodontitis. Then the noxious agents they moved into the root canal causing the endodontic involvement, and this is called primary perio because first the primary is the perio, that is first involvement is the periodontal structures because of the periodontitis, and then the root canal was affected. Then comes the true combined endoperio lesions, that both the lesions were present, that is periodontitis was present, root canal was inflamed, and those lesions they have communicated with each other and now they have meet each other. That is the true combined endoperio lesion. Then comes the concomitant, that is both the lesions are present, they have not communicated with each other and independently have their own survival around the tooth surface. So, how to differentiate between the pulpal as well as the periodontal lesions? Now, as we know, pulpal infection will be there in pulpal disease. Then in periodontitis, the periodontal involvement will be there. The tooth structure, that is the vitality, which is dictated by the blood vessels, that's the vascularity of the tooth, will be, the pulp will be in pulpal disease, it will be non-vital, whereas in periodontal, it will be vital. Restoration will be may be present, deep restorations are already present, caries will be present during the pulpal involvement, whereas it is not present in periodontal. Plaque and calculus is primary consideration for the periodontitis, whereas not so in pulpal. The inflammation is acute in pulpal, whereas it is chronic in periodontitis. Pockets, they are the main criteria in periodont disease, which will be wide, multiple, whereas during the pulpal, it will be single or narrow. The trauma can be present in the pulpal disease, whereas not so in periodontal. The microorganisms which are present are complex in periodontitis than those of the pulpal. When seen on radiograph, the lesion will be localized wider apically in the for the pulpal disease, whereas it is wider coronally and generalized in case of periodontitis. Then vertical bone loss is generally seen in the periodontitis and not in case of the pulpal involvement. Also, because of the presence of, we have seen the periodontal pocket formation, so which is not seen in case of the pulpal, whereas it is seen in the periodontitis. So treatment for pulpal disease will be root canal treatment. For periodontitis, it will be the scaling, root planing, which will be followed by surgical phase. Now, how to diagnose it? First, take a complete case history of the patient, why it was there, how it origin, what is his past dental and medical history, and then on examination, first go for the visual examination, the condition of the gingiva and the tooth. Then palpate that area. If it is soft, edematous, any sinus is present, pus discharge is there, check for that. Then percuss the tooth, whether it is tender on percussion or it is not there. Check for the mobility of the tooth. Pocket probing has to be detected. Then check for the vitality by using cold test, heat test, as well as by electric pulp testing. Then restored teeth testing has to be done. On radiograph, we can see the bone loss, which can be horizontal, vertical, or there is no bone loss. Fistula has to be tracked from where the origin is there, whether it is towards the canal or it is towards the pocket. Then crack tooth testing has to be done, and the selective anesthesia. Sometimes patient is not able to locate the tooth where the pain is there. So give a selective anesthesia, detect whether it is relieved or it is not relieved. If relieved, that means the you are on the right tooth. Coming to the treatment part, primary endo lesion is there, go for endodontic therapy. Primary endo with secondary, go for first endo, which will resolve, and then go for periodontal treatment. If it is primary periodontal lesion, go for periodontal therapy including scaling, root planing, curettage, then followed by surgical phase, which will include the surgery included chitoid tissue regeneration, or if required has to go for root amputation, hemisection, and pulp space therapy. Primary periodontal lesion with secondary endo also involves the pulp space. Go for root canal, which will be followed by periodontal therapy, root amputation, and GTR. Then comes the true combined, same, that is endo done first, then periodontal, hemisection, and root amputation. Now, how do you follow the case of endoperio lesion? First, determine that what is the cause for that lesion. It is endo, it is perio, it is fracture, root resorption is there, or any anatomical variation is there. Check for first the endodontic status, whether the tooth is already treated for root canal or root canal has not been done. Now, if root canal has already been done, go for the X-ray, whether the preparation is properly done, it is over, under, or perforation is there. Check the obturation, it is correct or it is not correct. If not so, if we evaluate it is not adequate, then check whether we can again do the root canal or we cannot do the root canal. If it is not root canal treated, check for the vitality, whether the tooth is vital or it is non-vital. Now, in case of the root canal treated tooth, if the root canal is not feasible, go for the scaling and root planing. That go for the debridement, and if it is resolved, then it is okay. Otherwise we have to go for the extraction. Now, if the root canal treatment is feasible, first do scaling, remove the local factors which are present in that area. If it is resolved, then it's okay. If it is not resolved, go for re-RCT. After re-RCT, check again. If the lesion is resolved, then it's okay. If it is not resolved, go for extraction. In case it was not treated, that is it was not a RCT case and the vitality test is positive, go for the perio treatment. If it is resolved, it is okay. If it is not resolved, again check the vitality and do the RCT. Still not resolved, go for the extraction or resection or hemisection. If it is non-vital tooth, go for root canal treatment. Then if it is resolved, it is okay. If not resolved, check again for periodontal condition. Still not resolved, go for extraction or resection or hemisection. So this is how we proceed with the endoperio lesion case, and I hope it is clear. Thank you.